On behalf of our entire school community, 200 faculty, 1,200 students, 18,000 alums worldwide, I want to welcome you to this truly extraordinary gathering on social forces, clinical cases, breaking boundaries with the Lancet's Global Social Medicine Cases and Sir Michael Marmot. Now, I have to say, I am so proud to be co-hosting this event, which helps launch a new monthly series in the Lancet designed to change the conversation in healthcare. The series features real clinical cases from around the world, going beyond clinical diagnosis, bringing critical lens into the social and cultural forces shaping the patient's condition. Each article co-authored by social scientists and health professionals with input from the communities themselves, and each unpacks a framework or concept from the social sciences and humanities, not just to deepen our clinical understanding, but to change how we practice, how we lead, and how we make policy in healthcare, ultimately creating what the authors call a translational social medicine toolkit to help address the deep social and structural causes of global health inequities. Now, before we begin, I want to start with gratitude to our partner sponsors, Berkeley Center for Social Medicine and Institute for the Study of Societal Issues, and the many, many co-sponsors, as well as all the event organizers, including our own Alicia Slater, Denise Herr, Mahazam Jahid, and Amani Nurajiter, and everyone who made today possible. Thank you for bringing all of us together. To all the co-authors of this series, thank you for pushing us to think differently and more deeply about what really drives health. And to all of our speakers, many of you travel a long way to get here from Algeria, Mexico, Spain, Sweden, UK, US. Thank you for being here. Thank you for sharing your work with us. I want to give a special shout out to Sir Michael Marmot, one of our most influential alums in our school's 83-year history. Along with Len Syme, Sir Michael Marmot helped pioneer the field of social epidemiology and the idea of social determinants of health, which is truly one of the most powerful ideas in medicine and public health in the last 100 years, and one that continues to shape healthcare and public policy here in the US and around the world. If you'd like to learn more about his time here at Berkeley, we just published a wonderful conversation with him on our website. And last but not least, I want to give a big shout out to Professor Seth Holmes. He, along with Dr. Mayssa Rekhis and Dr. Mirko Pasquini, whom he will introduce, is co-leading this article series in Lancet. I'm grateful to Seth for bringing us together today. And without further ado, let me go ahead and introduce Dr. Seth Holmes. Yeah. Dr. Holmes is a medical anthropologist and a physician who is an affiliated faculty member of the School of Public Health with a primary faculty appointment in environmental science policy and management, and founder and co-chair of Berkeley Center for Social Medicine. He works on social hierarchies, health inequities, and the ways in which such asymmetries are naturalized, normalized, and resisted in the context of transnational immigration, food systems, and healthcare. He has received numerous national and international awards from the fields of anthropology, sociology, and geography, including the prestigious Margaret Mead Award. Please join me in welcoming to the podium Professor Seth Holmes.
Thank you, Dean Liu. Thank you all for coming today. It's a pleasure to be here at Berkeley and in the Brower Center. This next section for 15 minutes will introduce you to this article series, The Lancet Cases in Global Social Medicine. We'll explain what it is, why we've been putting it together, some of the people we've been working with. First, I'll introduce Dr. Mayssa Rekhis, who completed her medical studies, her MD in Tunisia at the University of Tunis, and then her PhD in psychological anthropology at the École des Hautes Études en Sciences Sociales, the School for Advanced Studies in Social Science in Paris. She's an artist, an anthropologist, and a medical doctor who puts them all together, for example, in her recent book, Midwife's Archive. I'd also like to introduce another member of the project team, Dr. Mirko Pasquini, who's a medical anthropologist in the School for Global Studies at the University of Gothenburg. He teaches structural competency in new environments, including in Italy, Sweden, Denmark. And his recent book with Rutgers Press is called The Negotiation of Urgency, where he works with ER physicians in Italy to think through all the economies of attention in such spaces. I'll pass it to you.
Thank you so much, Seth. And I'm honored to present this initiative to you today. And before we turn to the case presentation from Tijuana to the Sahrawi refugee camp in Algeria and Sir Michael Marmot, a keynote lecture, let me briefly introduce the Lancet Global Case Series. So what is the series about in practice? So published in the Lancet, the series brings together medicine and the social science in new spaces for knowledge, but importantly, new spaces for action. And the goal is to understand social forces shaping health worldwide. And the core idea, it is to seriously confront what is wrong with the world today and what to do about it. Of course, there are limits on our current approaches in public health. Interventions across levels of individual, community, and policymaking have tried to face the 2008 financial crisis, the Ebola epidemic, the rise of discriminatory politics, the COVID-19 pandemic, and the ongoing global conflicts. And many of those efforts have fallen short. Why do we fall short? Often they only scratch the surface. They do not often address the deep structural roots of harm. The policies, the institutions, and economic systems that maintain and create these structures of harm. Second, they often lack true collaboration. Key actors rarely sit across the same table. Health professionals, social scientists, patients, activists, and community members very often do not mix their expertise. And this creates a limited understanding of those root causes and also weak and fragmented solution, the possibility to act. And this is precisely what this series wants to change. We need more and more to live up to the WHO definition of health as a physical, mental, and social well-being beyond just the tackling of disease. And we have learned from partners in health the role of public health, but it should be about empowering people and about enable them to thrive, to be happy, to have joy and dignity. And this, of course, requires new ways to understand and act over social forces. And this is what the series tried to do. So what does the series do in practice? Is the slide? Okay, I'll just go. Okay. Sorry. The series focuses on social structures, which are the policies, the institutions, and the economic systems. And the series basically examines how they create inequities and harm in practice. And it goes into the mechanics of what in practice happens and how we can act upon it. It examines deeply using all the tools of social science and public health combined. So it builds shared understandings across different actors and to create solutions and solidarities among those actors. So we are inspired by what Sir Michael Mohamed said in relation to why we treat people and send them back to the condition that made them sick in the first place. At the same time, we're also very aware with Jaime Braille that the structural processes incompatible with life and health are accelerating globally. In other words, time is running out. Yet, health professionals feel unprepared, feel to face these social forces. Their education, means, and possibilities often fall short as well. And they feel unempowered. And many of the people I've been working with in the emergency room, and the Italian doctors and nurses that I've been working with overcrowding in the ER, they often have told me that, what can I do about social structures? I'm a single person or just a single department. How can I address all these problems that are just too big for me to try to tackle? So the series wants to give health professionals hope and tools and practical tools to address this. And the series uses real clinical cases to show how social forces shape illness and care in practice. And it works across individual, community, and policy levels to see the interconnections between all these different levels. And social concepts become practical tool, not just abstract theory, to shape a global social medicine toolkit, to act on the root causes of harm and illness. And in this sense, the series wants to be translational, in the sense that the insight coming from social sciences, from society, are brought into the clinic. And from what happens into the clinic, then they're brought outside to influence policy and structural change. And this, of course, is a cross-disciplinary and cross-geographical effort. And the focus is on why things happen and what can we do about them. So it's very practical. And cases are global in scope. Indeed, we talk about refugee camps, we talk about rural clinics, urban hospitals, diverse healthcare and geographical settings. And all of this to build shared understandings across different communities of similar social forces, to inspire different communities across the globe facing similar problems, in order to create solidarity and global solutions.
Thank you, Mirko. Next slide, please. What I will try to explain next is how did we come to make this series that Mirko introduced. We wanted this to be an international, collective, and interdisciplinary process in order to co-develop a toolkit together that emerged from diverse contexts, but that can be useful in so many other contexts. And this is what we mean by global in that sense. This we designed intentionally a collaborative space and process that go through different phases that I can describe. We started with a targeted call for cases that we try to reach, especially areas that usually do not make it to public and international journals and spaces. So in order to make sure that knowledge emerges from different contexts. We did our best using our network to reach these areas. These are, of course, imperfect results, and we can still improve that in the next phases. But we did receive more than 300 abstracts from all over the world. Out of these, we selected 24 and tried to have different criteria, such as the diversity of themes, of issues, social forces they describe, and the diversity of geographic areas. We had author teams of all these 24 cases that were interdisciplinary, coming from medicine, health policy, social sciences, community members, and so on, with the support of an international editorial board that came also from different disciplines. We came all together in a series of workshops. One of them was an intensive 3 days workshop in person, 4 time of discussions, feedback, revisions, iterative, and coming back and again, and continued online after these 3 days, as it is a longer process than a 3 days work, until we went into the submission. Next slide, please. But of course, you can imagine this was a long, intensive, difficult process, also very inspiring and rewarding, that took more than 3.5 years, actually. And thus we needed a very big, hardworking team of editors that came from all different disciplines, but also from all continents, except Oceania, because we do have Sir Michael Marmot, who's Australian, but currently based in London. And we do have also an amazing team of project assistants who are MD, PhD graduate students, and many of them are also activists, advocates. All the team, editors and editorial assistants, come from the worlds of either medicine, or health science, or social sciences, or both. Many, actually the majority, have a dual training in both disciplines. I won't go through all the names, but I invite you to meet many of my colleagues who are present today in the room now and in the reception. Next slide, please. And what I want to focus on specifically is these workshops. The 3 days intensive workshops, these were a key in our process because it is surprisingly difficult to write a compelling case. Next, please. That has a clinical case, that respects the clinical case format. Familiar for clinicians, this is how we are used to learn in a format of clinical case. But that also has a clear social force in action that we can see is impacting the health outcome, has a rigorous social analysis, and is actionable, because this is mainly that. When physicians, health professionals ask, what can we do? That we can offer them possibilities. What can we do? This is why we needed a collaborative process, a workshop where people sat together, putting efforts together and bringing together their different expertise. Around the same table, thinking together, giving feedback to each other, we tried to break hierarchies in practice in a way, and I think we succeeded to a certain extent, because we did create a space where people were sitting together on an equal basis. So you have a few photos, and I want you to imagine you were there in these rooms with me. In the morning, around one table, we do have a farm worker from rural Florida, a doctor from the West Bank from Palestine, and a sociologist from France, and many others sitting together, reading their cases and giving feedback to each other. In the afternoon, they will go, take this feedback on, and try to rewrite in their author's team. Tomorrow morning, they will come in different constellations, and imagine again, a health agent from Yanomami in the Amazon sitting with a doctor from Taiwan and an anthropologist from Harvard, all thinking together, discussing, giving feedback to each other's cases, and testing the concepts, trying them until they can create together, next please, a strong, understandable, and useful toolkit based on this feedback and discussions. Next. Yeah, so there were many rights between sessions, and this was the really key in making these strong cases. It was a collaborative effort, and people worked together in it.
Next slide. So Mayssa just talked about this toolkit made up of different cool tools from different articles that are based in cases. Some of the cases are of individual people, patients, sometimes health professionals, and some of the cases are of communities. But what does this toolkit consist of? How do we work on these cases? Again, I will emphasize that it's surprisingly difficult to write a short case that's legible and understandable to health professionals who are used to a very certain way of writing, that also incorporates rigorous and deep social science analysis and can be applied in multiple different contexts. Surprisingly hard, surprising many of hours of many people. So the first thing that we focus on is the inflection point, the moment in which something could have been different, the moment in which, instead of feeling powerless as a health professional, as a public health practitioner, we can see that if we acted differently in that moment on those social forces, the outcomes would have been different for the patient, for the community, for the health worker team. So in a way, this inflection point is meant to show where action on the social determinants of health in society, on different aspects of this social cultural interactions would change things. The second aspect we focused on was having a social theory concept that we could share that wouldn't be totalizing, explaining the whole world, but also wouldn't be just descriptive in that one context, but it would be something people could understand that context and then think, oh, I'm going to take that idea with me and apply it in Arizona or Berkeley or South Africa or wherever I work. The last aspect that we found serendipitously enjoyable was skepticism in a certain way. Not only writing for a skeptical reader, but writing with skeptical writers. Having a clinician who listens to the anthropologist and says, why the hell are you using all this jargon? Or the anthropologist or sociologist who says to the public health worker, I don't understand what you're writing about this GFR or whatever, or a community member who says, like, what does this have to do with what's going on in society, and having to rewrite together, having to write together, having to make knowledge together. Next slide. So each case is written in this way. We're behind because of AV. You'll see examples soon. Global social medicine is transdisciplinary. Next. It is coalitional. Next. And it's ongoing. The intention of this series, which I would have been able to see here, I'm sorry, but we're doing great, is to give new lenses for local action, for us to engage the increasing discrimination, authoritarianism, and inequities that we see in the world. Our intention overall is to help orient practice and for this toolkit to become a source of solidarity as we organize as health professionals, as social scientists, as community members, to confront these obstacles to health and well-being for all in the world. At this historic moment, we must build coalitions across boundaries, even if they're unexpected coalitions, and we have to engage in solidarity across difference. Next slide. Many groups funded this process and supported this process. Some of their names are here. The only one I'll mention right now is that we, with the support of the Berkeley Center for Social Medicine and others, and Theo Michaels, wrote a grant and were successful in getting funding from the National Institutes of Mental Health, which has been under great attack by the federal government, largely defunded. Its wonderful director fired by RFK Jr., and this grant was terminated by the federal government. But after a successful class action lawsuit, partially by Berkeley colleagues and the American Public Health Association, it was reinstated. And so we were able to bring all these people from different places here today to meet you and talk with you. These are the funders within UC Berkeley. I also won't read them, but please thank them, send them an email. If you know them, smile at them. If you scan this QR code, I want to highlight that today we'll present 2 cases, but there's 6 already published and there's 1 every month. So you can follow this website that's being built so that every month you can see the new case. I will remind us in this moment of universities, including the University of California, being attacked and targeted, and grants being terminated if they have the word health or the term health equity, which this one did, that we need to support students, universities, and research. We need to keep working on building coalitions and engaging in solidarity.
Good evening, everyone. My name is Christian Yanez. I'm a 4th-year MD PhD student at UCLA in the Department of Anthropology. My research focuses on thinking of revolution as care, as well as revolutionary care in the Guatemalan highlands. And it's my pleasure today to introduce the first case authors who are joining us, who are incredible thinkers, clinicians, and comrades. Hannah Janeway is an assistant clinical professor of emergency medicine at UCLA and a co-founder and co-director of the Refugee Health Alliance. They work as an emergency physician, street medicine provider, and as an activist towards the creation of health equity in the United States and abroad. They specialize in healthcare for immigrants and the unhoused, and their advocacy focuses on ending state violence and carceral forces in hospitals, the community, and at the border. Carlos Martinez is an assistant professor in the Department of Latin American Studies and Latino Studies, and core faculty member of the Global and Community Health Program at the University of California, Santa Cruz. Trained in public health and medical anthropology, Dr. Martinez's research examines the health and sociocultural implications of policing, incarceration, and punitive immigration and drug policies. He is the co-editor of All This Safety is Killing Us, Health Justice Beyond Prisons, Police, and Borders, and hopefully a forthcoming manuscript in the next year. Shamsher Samra is an assistant professor of emergency medicine at UCLA and former co-chair of the Structural Racism and Health Equity theme at the David Geffen School of Medicine at UCLA. He currently serves within the Los Angeles Department of Health Services Community Programs Division, focusing on initiatives that support individuals impacted by the carceral system, and currently is a board member of Doctors for Global Health. His academic and professional interests center on liberation medicine, the practice and teaching of healthcare as a tool to promote collective well-being and cure structural violence. Todd Schneberk is an associate professor of clinical emergency medicine, director of population health for the Department of Emergency Medicine, and co-director of the USC Keck Human Rights Clinic. As a health services researcher in the safety net, his research encompasses immigration and border health policy, social care delivery, Medicaid policy, and vulnerable populations who utilize emergency care. Please join me in welcoming our first case authors.
All right, thank you so much. We're going to talk today about a case of structural intercompetency, a case of an asylum seeker with abdominal pain in Tijuana, Mexico. So today I'm going to talk about Daniel. He's a 45-year-old asylum seeker from Ghana who presented with severe abdominal pain to a medical clinic in Tijuana, Mexico, which provides free primary care services and meets social determinants of health for migrants requesting asylum into the United States. Daniel tells Dr. V, who's an emergency physician from Los Angeles, who's volunteering at the clinic, that he is here because he experienced persecution for becoming romantically involved with another man in a small village where he's living in Ghana. And although he tried to keep this relationship a secret, a group of young men came one day and violently attacked Daniel for being gay. And after leaving him for almost dead, Daniel was able to flee to the capital city, where they kind of followed him and eventually fled to Ecuador, which at the time was a visa-free country where he could go with just a tourist visa. When he got there, he met a group of other migrants and was able to travel northward through like a pathway that a lot of people do that goes up, crossing into Panama through the Darien Gap, and then all the way up to the US-Mexico border to Tijuana, taking buses and other means of transportation, of course, walking through the jungle. Dr. V sees Daniel, and through testing and an ultrasound that he performed, he diagnoses him with a large urethral stone, potentially precipitated by dehydration during his migratory journey. He explains to Daniel that he needs to have a procedure called a lithotripsy, which is a procedure that breaks really large kidney stones into very small passable fragments because the stone was too big to just pass on its own. Unfortunately, neither this small health clinic that really just provides primary care nor the public health care system in Mexico could provide this procedure. And as he's explaining this, Daniel says, well, that's okay. I have family in the United States. I don't plan on being in Tijuana for very long. I'm going to cross the US-Mexico border through a route that without any sort of authorization. And then I'm just going to request asylum directly there because he had heard that it was taking many months of waiting to get formal authorization to cross the border. Knowing that he'll cross imminently, Dr. V assumes Daniel will soon be able to receive treatment at a hospital in the United States, so just prescribes medication that would aid with the stoned passage and also some medication for pain. A few weeks later, Daniel does cross the border through a mountainous area just to the east of Tijuana, and as what normally happens, he's detained by enforcement agents, CBP. He is in a CBP detention facility, and then eventually he's transferred to a migrant detention facility operated by Immigration and Customs Enforcement, also known as ICE, the U.S. federal agency that oversees immigration, as a result of some new policies that were in place that expanded the incarceration of asylum seekers. So at one point, more people were being let into the community, but at this point, they were incarcerating a lot of people, and he was placed in ICE detention. Next. While in detention, Daniel calls a hotline telephone number operated by a group called Migrant Advocates, which is a nonprofit human rights organization that monitors conditions in ICE detention facilities and advocates for migrant decarceration. He tells them that he's been denied medical consultation despite experiencing severe pain, and Migrant Advocates provides legal assistance to him, submitting complaints to the facility's warden. In response, ICE does allow Daniel to receive a medical consultation from a jail physician, but he's not given adequate pain control, medication, or a specialist referral, as was pretty typical at that time, honestly. Next. Migrant Advocates then contacts Dr. V to request medical records after Daniel kind of explains that he's been to this clinic in Tijuana, that they diagnosed him there, that he has evidence that he does have this kidney stone. Now, Dr. V has never really worked with an advocacy organization on a patient case, and he's concerned about privacy laws and becoming involved in a potential court case or lawsuit, or maybe he would have some sort of retaliation from the hospital he works for. But he also knows that Daniel's at risk of infection or permanent loss of his kidney function if the stone is left untreated. This is the inflection point, Dr. Holmes. So he's concerned, but he decides that he's going to proceed and help with this case. So Daniel works with migrant advocates and an immigration lawyer to send a letter to ICE officials requesting the provision of adequate medical care. So with the guidance from migrant advocates that had some templates from other doctors they'd worked with in the past, Dr. V was able to contribute to this letter, and migrant advocates also submitted the documentation to the Department of Homeland Security's Office for Civil Rights and Civil Liberties and organized a telephone and letter writing campaign. Next. Oh, you can go back one, sorry. So after being held in detention for more than a year, this advocacy actually played a part in freeing Daniel and some other detainees from ICE custody. Daniel eventually received the procedure he needed 5 months later in a safety net hospital in Los Angeles. And although Daniel obtained definitive treatment, unfortunately, his incarceration exacerbated his underlying PTSD, and he also sustained moderate permanent kidney injury secondary to this obstructive uropathy. He is now a legal permanent resident, lives with his asylum sponsor family and his children who have now immigrated from Ghana.
So Daniel's case is emblematic of the harms that permeate the experiences of marginalized populations, particularly migrants and asylum seekers, and also demonstrates the critical role that health workers can play in advocating for them. The advocacy that Dr. B engaged in is an example of what we refer to as structural intercompetency, the trained ability to work effectively within a multidisciplinary team of practitioners, including those from beyond the health professions, to address social, political, legal, and economic processes that may be impacting a patient's health. This entails understanding how clinicians can collaborate with partner organizations, including legal, social service, and advocacy groups, to support patients' health and healthcare. Structural intercompetency is a term inspired by the concepts of structural competency and interprofessionalism. Structural competency, on the one hand, denotes a clinician's capacity to become familiar with and act on the social and political determinants impacting the health of their patients, such as economic inequality and immigration policies. Interprofessionalism, on the other hand, seeks to integrate a variety of health practitioners, such as doctors, nurses, and social workers, to collaborate within healthcare teams. Structural intercompetency can improve health outcomes among a variety of patient populations, not only migrants and asylum seekers. It can be a valuable practice when advocating for patients impacted by political and social inequalities with which physicians or healthcare workers of any kind might have little experience. For example, structural intercompetency can be used to advocate for patients who may be experiencing negative health impacts associated with racial or gender-based discrimination, political persecution, domestic violence, homelessness, incarceration, or occupational-related harms. These alliances can engage in various strategies, including such practices as direct material aid, education regarding institutional abuses, legal action that confronts deviations from human rights, and broad-based campaigns aimed at challenging policies like the kind of Professor Janeway was just talking about with migrant advocates.
Thank you, Carlos. So there's several ways that structural intercompetency can be put into practice in clinical settings, in the global health setting. The first is that recognizing that professional and structural humility is a prerequisite for structural intercompetency, for us to be able to work effectively in a collective fashion. While professional humility encourages clinicians to diminish power imbalances within occupational hierarchies, structural humility calls on us to collaborate with patients and communities in creating responses to social and political inequalities. For clinicians, this requires a process of intentionally unlearning and relearning practice in three key ways: challenging medical hierarchies, valuing and incorporating community knowledge and expertise, and lastly, expanding the sites of care beyond what may officially be sanctioned. For trainees, structural intercompetence demands that we include the social, political, and legal landscape that impacts patients in medical education. Currently, physician education continues to primarily focus on biological aspects of disease. Medical schools should instead integrate community leaders and organizers to discuss their work, how it impacts patients, and how physicians can collaborate with them to advance health, and most importantly, participate in acts of solidarity. Yet, as many are aware, this is the exact type of medical education that's currently under attack on multiple fronts. Recently, the LCME, the main medical school accrediting body, removed structural competency as a requirement for medical school accreditation. At the medical school level across the country, institutions have either been unable or unwilling to protect curricula, students, faculty, and community members from attacks on education regarding the intersection of health, racism, capitalism, gender justice, and genocide, amongst other things. Instead, institutions have responded with overt violations of academic freedom. Furthermore, they have responded to these threats by limiting the inclusion of community speakers and knowledge, justifying the decision with the claim that people outside the academy lack the expertise to be educating medical trainees. We must not only respond to these attacks on institutions, but also work with community to create new spaces of inclusive pedagogy and praxis outside institutions in order to advance structural intercompetency.
Thank you, Shamsher. So my role here is to talk about the utility and the importance of medical legal partnerships in this setting, and specifically to try to achieve some of the goals that Shamsher was just alluding to in terms of community pedagogy. One of the things that you see in this medical legal partnership and the way it functioned for Daniel is that you see that this pivotal piece of the community group and this mutual aid organization that was the go-between. And even though medical legal partnership starts with medical, the medical part is actually probably the least important, secondary being the legal, and then having this group of the community that is able to both build trust with Daniel and then also respond to what his needs are throughout the course of his detention as well as his migration is critical. And so our job in building these medical legal partnerships is really to take this institution, this infrastructure, leverage the credibility among the medical and legal side to be able to elevate community groups and the community expertise that is there among, in this case, this mutual aid organization. And this can be difficult in these hyper-regulated environments and against some of the headwinds we are facing right now among federal and other regulations against what we see as our academic freedom. But some of the solutions to that is that we have to take both extra institutional and intra-institutional strategies and build coalitions within both of those spaces. And some of the advantage of, in this case, of an intra-institutional medical legal partnership is that we're able to use and leverage this institutional power and this hierarchy for the betterment and the elevation of a case like Daniel's, which is typically under traditional power structures impeded by our power structures in terms of his health. And so the last thing I want to say that's kind of cut off by this is just that we also have some of the fruits of these medical legal structures in our own kind of LA community, which has been building out these anti-carceral movements, which resulted in the canceling of a mental health jail contract in LA. More recently, as ICE has continued to encroach on medical care and try to influence care within our healthcare spaces, being able to come together as the People's Care Collective, building coalitions to both build policy and build protection for our patients in the face of ICE interference. And then one last piece is that being in the positions these medical legal partnerships are in, they're often poised to respond in the moment to situations. One of which was a case where a detainee was actually undergoing a hunger strike because he was protesting his working conditions in the detention center he was at that were unjust. And he was transferred to a facility in Texas known for force feeding people who are on hunger strike. And we were already working with them through an education program within this group of networks. And as a result, when he was transferred to be force fed, we were not only able to leverage legal aid, but also when he eventually was force-fed, the silver lining being that we were able to push for his individual case to be taken and then larger class action with ACLU, which is going to result in his ultimate ability to stay in the country.
Good evening, everyone. My name is Sadia Dembi. I'm a second-year MD PhD student here at Berkeley and UCSF. I study networks of care, African urbanism, and necropolitical resistance in Sierra Leone. I have the privilege of introducing our next group of speakers who will be discussing their case on the role of improvisation and care delivery in the midst of incredibly precarious environments and infrastructures. Salek Ali Mohamed Elabd is a specialist physician in family and community medicine, completing his residency training in Orihuela. Since 2009, Dr. Salek has combined clinical practice at the Vega Baja University Hospital with primary care, as well as lecturing at the Valencia School of Health Studies. For several years, he has been involved in providing healthcare in the Sahrawi refugee camps, where he works as a physician for several months each year, combining on-site medical care with telemedicine consultations and ongoing professional collaborations with medical colleagues in the Sahara. Maria Carrion is a journalist, human rights, and cultural activist currently based in Madrid. She is the executive director of the Western Sahara International Film Festival, and in 2018, she co-founded Nomads HRC, which is a Madrid-based NGO that works on cultural, film, media, and human rights projects in the Western Sahara. Maria has an extensive media and communications background, previously working with Democracy Now!, Elabd, The Progressive, NACLA, and Amnesty International, just to name a few. Theo Michaels is an MD PhD student in medical anthropology at the University of California, Berkeley, and San Francisco. His research examines the psychological and structural dimensions of the US trucking industry, with particular attention to migratory politics, occupational health, and surveillance. To support this work, he obtained a commercial driver's license and has performed partisan observation with drivers. His broader work explores the social life of the political right, which has included a study of conspiracy theorists in England and another on responses to progressive behavioral healthcare reform in California. Complementing this research on reactionary politics, he examines the consequences of colonial displacement and violence. Please join me in welcoming this amazing group of presenters to the stage.
So I'm going to start by giving some context to this case. Western Sahara is a territory, is a resource-rich territory. It's home to around 400,000 Sahrawi indigenous people, located in North Africa along the Atlantic coast. It borders with Morocco on the north, Mauritania on the south and east, and Algeria on the east. It's a former Spanish colony. You can click to the next one. It was colonized by Spain until 1975, when Spain withdrew from the territory and allowed Morocco to invade it. Morocco's invasion was both a resettlement campaign, sending hundreds of thousands of Moroccan settlers across to Western Sahara, and also a military campaign. The population was brutalized, and half of the population was forced to flee into Algeria, where they settled in refugee camps. While they were fleeing, they were bombed with white phosphorus. So currently, half of the population lives in these refugee camps in Algeria, which if you click again, there you go. And Morocco, and in the Morocco-occupied Western Sahara is home to the other half of the Sahrawi people. There was a 16-year war between Morocco and the Polisario Front liberation movement. Morocco built a separation wall. It's the world's longest separation militarized wall. You see that in the dotted line that divides the yellow part, which is occupied Western Sahara, from the orange part, which is the liberated territories, the Sahrawis call it. In 1991, the UN brokered a ceasefire promising a referendum on self-determination for the Sahrawi people. However, this referendum has not taken place. So Western Sahara continues to be a non-self-governed territory. Next, please. This case takes place in the refugee camps in Algeria. When the Sahrawis arrived in the camps, they created a government in exile called the Sahrawi Arab Democratic Republic, or SADR. They were founding members of the African Union, recognized by numerous countries, but not by countries in the West, rendering much of the population in the camps as stateless. They depend on dwindling and insufficient humanitarian aid, and the population lives in very harsh conditions in this part of the Sahara Desert, including extreme climate, temperatures of over 50 degrees Celsius. And the Sahrawi Republic's Ministry of Health administers the health to the Sahrawis using a wide network of volunteer work.
Gracias a todos.
Thank you, everyone.
Me gustaría que por unos segundos imaginar un hospital sin corriente eléctrica.
I'd like to ask you for a moment to imagine a hospital without any electricity.
Pues justo eso es lo que nos pasa en un hospital de referencia que tenemos donde trabajamos en los campamentos de refugiados saharauis.
This is exactly what happens in the hospital where we work in the refugee camp of Sahrawi people.
Las altas temperaturas estropearon el generador y estuvimos sin electricidad durante 35 días.
The extreme temperatures broke the backup generators such that we were out of electricity for 35 full days.
Pues en ese momento teníamos dos opciones. Una era cerrar el hospital y la otra es seguir trabajando e improvisar.
We had two options. The first was close the hospital. The second was keep working and improvise.
La primera opción no era viable porque dejaríamos sin asistencia médica a más de 70,000 personas.
The first option wasn't viable because we would leave more than 70,000 people without access to any kind of care.
La gente sigue enfermando y las urgencias siguen llegando.
People still get sick and urgencies or emergencies continue to occur.
Además de que el hospital más cercano estaba a 2 horas de viaje, teníamos una sola ambulancia y las carreteras pues no están asfaltadas.
This is on top of the fact that the nearest hospital is 2 hours away. We have just one ambulance and none of the roads have asphalt. They're all dirt roads.
Por eso no era viable y la que era es la segunda opción, que es trabajar e improvisar.
So really the only option was keep working and improvise.
En una de las guardias por la noche
In one of the overnight calls,
nos llega Mariam, que es una paciente joven en trabajo de parto.
we met a young woman named Mariam who was in the midst of labor.
Pues con nuestras linternas tuvimos que conducirla a la sala de parto a través de los pasillos oscuros del hospital.
So in the middle of the dark corridors of the hospital, we used our flashlights to get the birthing room ready.
Cuando llegamos, el material es muy poco y vemos que no había mucha luz, que necesitamos más luz.
We realized that with the flashlights, there wasn't enough light and we needed more light.
Pues tuvimos que improvisar y poner un coche afuera para que nos ilumine a través de la ventana y así tenemos más luz.
So what we did is we put a car outside the windows, turned on the headlights and had it come through the windows.
Y así con el cuidado de no obstruir la luz del coche, empezamos el parto.
So we had to be careful while we were taking care of the patient not to make shadows and block the light in order to help her with her birth.
De repente nos interrumpen gritos de afuera.
All of a sudden, we're interrupted by shouts from outside.
Era Sidi, un niño de 14 años que viene por una mordedura de serpiente.
A 14-year-old boy named Sidi arrived after being bitten by a snake.
En ese momento el equipo se tiene que dividir. Intentamos relajarlo, controlarlo.
So our healthcare team had to split, and part of us started working with him in order to keep him calm and control the pain.
Buscamos el antídoto.
So we looked for the antivenom.
Y resulta que no había antídoto.
We realized there wasn't any left.
Pues tuvimos que aplicar lo que es la medicina tradicional saharaui, que es a base de resina de acacia, que es una planta conocida, y aplicarla al niño.
So we used an indigenous treatment practice using acacia resin.
Y de repente nos llega Fátima, una chica con el brazo roto, visiblemente deformado.
All of a sudden, a young woman with a broken arm that was visibly deformed arrived.
No teníamos servicio de radiología ni tampoco teníamos material para inmovilizar.
We didn't have radiology or x-rays, and we also didn't have splints to immobilize the arm.
Otra vez tuvimos que improvisar, coger 2 palos, ponerlo uno a cada lado del brazo y una venda para inmovilizarlo.
So we had to improvise by finding strong branches, putting them on either side of her arm, and using bandages in order to keep the arm immobilized.
Discutimos entre dos el caso de Fátima y hemos visto que como que no es un riesgo para su vida, puede esperar al día siguiente para trasladarla al hospital donde hay rayos junto con otros pacientes en la única ambulancia que había.
Since we only have one ambulance and we don't know who else might arrive, the nurse and I discuss and decide that since none of these people are at risk of life or death right now, we'll wait and see what we need to do in the morning.
Pues así ocurre una guardia y esta no es una historia del pasado, es nuestra realidad cotidiana.
This isn't a history from the past. This is our reality every day.
Thank you, Dr. Salek. Approaching this case, our team kept returning to the question of how attempts to provide healthcare ethically unfold within infrastructures that are actually designed to fail. How can a clinician maintain their moral integrity when the gold standards that they learned during their training are rendered impossible by the circumstances of their practice? Or how can a health system like the SADRs be planned and implemented when colonial violence, like the burn pictured here, actively undermines its success? And so, to answer these questions, our team turned toward 2 social theory lenses important to the field of anthropology, and these are infrastructural violence and improvisation. So both of these concepts have a significant history that help to link the context of Western Sahara to the rest of the world. Back in the 1960s, the sociologist Johan Galtung coined the term structural violence to argue that many instances of violence occur outside of the individual dramatized instances we normally think of. Rather, it is manifest in what Galtung considered the objectively avoidable disparities in healthcare, well-being, and suffering. So instead of a man hitting a woman, perhaps an instance of domestic violence, millions of women face systemic oppression and violence, and this would be structural violence against women. In the 1990s, the physician anthropologist Paul Farmer brought the concept of structural violence into the clinic, naming it social oppressions machinery. And he argued that racism, sexism, poverty are not necessary risk factors for whose lungs get TB or whose body gets HIV. In our work, we draw from a set of scholars who push Farmer and Galtung one step further by highlighting factors of the built environment that inflict violence. So social scientists often think of infrastructure as the kind of invisible background of life. These are the roads, or the pipes, the wires, which only become evident when they break down. However, for those subjected to infrastructural violence, the break isn't the exception, but the rule. And it's a rule shaped by social, political, economic, historical factors. So when the workings of a colonial power or humanitarian aid systems lead to a precarious power grid, to a paucity of critical medical supplies, then the built environment, or actually like the avoidable lack thereof, quite literally becomes a weapon. We can think of border walls, or food deserts, toxic medical exposures. These all exemplify infrastructural violence. They are manifestations of systemic inequalities and are also producers of them in their own right. They are things that you can point to, but are also linked to broader policies. And like the infrastructures themselves, the policies can be changed. So if infrastructural violence were our sole concept here, then there would be little room for agency beyond the important work of advocating for changes in policy, political change. However, those like Dr. Salek provide ethical care within and despite these pernicious infrastructures. And so this leads us to improvisation. In the field of anthropology, Julie Livingston popularized improvisation as an analytical concept. So working in Botswana's Seoul Oncology Ward at the time of her research, Livingston found a phenomenon of cancer that was quite different from that in any wealthy nation. Not only are patients further along in their disease course when they access care, they often have HIV and TB co-infection and only have access to old and shifting access to old medications. So as a result, in cases like Botswana and Western Sahara, it's difficult to think of medicine as this kind of theoretical physiology that can be applied in the same way across the world. And that's because we don't know that much. We know comparatively little about such complicated imbrications of diseases, of epidemiologies, and so on. So we have to think of medicine as a set of improvised practices that are grounded in local resources, epidemiologies, and knowledges. In these settings, the risks associated with diverging from the gold standards of medicine become secondary to the creative work and also this ethical imperative of providing care within intractable circumstances. So, finally, improvisation can be deeply political. If settler colonialism seeks to replace or erase an indigenous population, then improvising to survive is itself a political act. It can be a clinician or a public health worker, even a whole health system pushing back against a structure, a force that has, in effect, attempted to quash the possibility of survival and well-being. So if an infrastructure is designed to dominate life, then improvisation can be a means of reclaiming agency over health destiny. It can be a group's health destiny or an individual's. Now, we pivot from this case's social theory concepts to its implications. And like the last case, these are the actionable interventions which we can draw from the case of Western Sahara to apply to the rest of the world. Our first implication: improvise to respond to social and political contexts. So up until very recently, standards in medicine were such that estimating the glomerular filtration rate, this is the rate at which we calculate the functioning of a kidney, its ability to filter blood, included a race correction factor. So playing off of this false biological notion of race, African Americans received delayed treatment for kidney disease as a result of a perceived artificially inflated kidney function. Before this race factor's popular repeal, there were doctors who cut out the coefficient, and we argue that these doctors were effectively improvising to respond to the racist conditions of medicine.
Nuestro sistema sanitario desgraciadamente es diferente.
Our health system is different.
No podemos aplicar la medicina clásica que se estudia en las universidades.
We can't always apply the medicine that we learn in our medical schools.
No tenemos producción propia, no tenemos garantía de medicamentos.
We don't have a guarantee that we'll have the medicines that we learned to use.
Por eso hemos creado una guía terapéutica.
So a collection of us Sahrawi medical doctors created a therapeutic guide for primary care in our context.
Básicamente es a través de todas las guías de la antigua medicina, de guerras, medicina de catástrofes, medicina militar, y así hemos hecho una guía con los primeros auxilios, cosa que ya damos en una escuela de enfermería que tenemos, y así cubrimos las necesidades.
So we created this guide, learning from battlefield medicine and other histories of therapeutic guides, and we teach it in our own Sahrawi Arab Democratic Republic government in exile nursing schools.
So Dr. Salek's examples of improvised innovations bring us to the last implication. Highlighting these innovations and bringing them to global attention and platforms can shed light on the unjust conditions that make them necessary, such as infrastructural violence. And this is done in many ways. In 2 weeks from today, the Sahrawi people in the camps will be celebrating the 19th edition of Fisahara. It's an international film festival taking place in the camps, and it celebrates Sahrawi identity, culture, but also in the context of colonialism. It sheds light on Western Sahara and everything we're talking about today. Fisahara screens are built on the side of humanitarian aid trucks, and it uses improvisation as a tool for resistance and to call out for justice. Dr. Salek and his colleagues continuously speak out. They recently joined Equal Health's campaign against racism to bring global attention to these unjust conditions caused by Western Sahara's colonization. And this is a necessary step towards ending it. Thank you.
Good evening, everyone. My name is Mayssa Mujahid, and I am chair of the Division of Epidemiology here at the School of Public Health at UC Berkeley. And it is truly an honor to introduce Sir Michael Marmot, one of the most influential epidemiologists of our time. His work has fundamentally reshaped how we understand health, not simply as a product of biology or individual behavior, but as something profoundly shaped by the social conditions in which people are born, grow, live, work, and age. Through landmark contributions, including the White House studies and work that began right here at UC Berkeley, he has shown us that health follows a social gradient and that inequities are not inevitable, but arise from unequal distribution of power, structures, resources, and opportunity. In this way, his work makes clear that health is at its core a matter of social justice. He has challenged us to, as we heard earlier, ask simple but profound questions like why treat people and send them back to the conditions that made them sick. And it forces us to confront our collective responsibility to create the conditions in which all people can thrive. But I want to share a more personal story about how I came to understand the power of his work. I first encountered Sir Michael Marmot, like many of us, as a doctoral student at the University of Michigan, reading his research, including his seminal work, and learning that social factors matter for health. But it wasn't until I became a new faculty member here at UC Berkeley, in conversation with my mentor, Dr. Leonard Syme, that his work truly came to life for me. Len Syme, who we lost earlier this year, but we had an opportunity to celebrate his life and legacy in September of 2025. He had this way of making ideas feel electric. If anybody had a conversation with him, you know exactly what I mean. But when he talked about Sir Michael Marmot, it was on another level. His eyes would light up in this unforgettable way. He would do his signature, whoa, and you would see his mind blowing right before your very eyes. And it was like he had been given this dose of vibranium or something powerful and transformative and infectious. It was infectious because I could feel it too. And this happened every single time he talked about him. I mean, every single time. So in those moments, I understood what it meant for one person's ideas to literally blow your mind. And I remember thinking, if I could do work that sparked even a fraction of that reaction, if I could see a hint of that spark in Len's eyes, then I knew I was on the right path. That is the impact of Sir Michael Marmot's work. He doesn't just inform, it inspires, it challenges us to ask deeper questions, to look beyond the clinic, and to confront the structures that shape health and opportunity across the life course. So it is with that same admiration, inspiration, and genuine delight that I introduce Sir Michael Marmot. Thank you.
If people ask me, why did you come to Berkeley? I'd say, because I like the introductions. You've heard this by now, the opening line of my book, The Health Gap. my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. What you've heard with this compelling series of case studies is how vital healthcare is, but in the context of these conditions. And we need to do both things, address the social determinants and address healthcare. This was what we put on the cover of the World Health Organization Commission on Social Determinants of Health report. Social injustice is killing on a grand scale. We published the WHO Commission in 2008, and I said at the time, somewhat naively, as a Spanish colleague said to me, when I said we wanted to create a social movement, he said, Michael, social movements are something special. There's a whole literature and understanding about how you do this. Well, in a way, we did it. In the wake of the Global Commission, I was invited by the British Prime Minister, Gordon Brown, to conduct a review to answer the question, how could we apply the findings and recommendations of the Global Commission to one country, England? I called my report Fair Society, Healthy Lives. I thought if I called it social justice, it was predictable that the Labour government was going to be replaced by Conservative government. Social justice sounds a bit like socialism, but fair society, you know, it sounds like the English playing cricket, you know, you've got to be fair. And then I was invited to lead a review in the European region of WHO, and then the American region for PAHO, North Africa and the Middle East, the Eastern Mediterranean region. In the middle, we published the Marmot Review 10 years on in England. Oh dear, it was bad news. You've heard a lot of bad news this afternoon. I'm going to give you more bad news. If you're a bit sensitive, I advise you to look away now and come back a bit later because I've got a glimmer of good news for you. And let me give you some context. I'm going to talk a bit about the UK. I'm going to ask you to make an assumption that everything I tell you about the UK applies to the US, only more so. So if we look at what happened to life expectancy in England, it had been rising. In fact, if you go back for 100 years, life expectancy had been improving about 1 year every 4 years. And in 2010, that rate of improvement slowed dramatically and just about ground to a halt. In fact, from 2009 to 2023, 14 years, we had no improvement in life expectancy. The implied promise is that health will get better all the time. And we broke that promise. 14 years. I don't know of another period in peacetime when life expectancy did not improve in 14 years. Now, the general assumption underlying my work, and you heard it in these case studies, is that health is a good measure of how we're doing it as a society. If health's not improving, society is not improving. So society, and I maintain the fiction that I am not party political. It stopped improving in 2010 when the Labour government, the Social Democratic government, lost and the Conservative-led government came in. But that's what the data show us. That's not party political. And if we look at what happened to inequalities, as you heard in the introduction, I've been harping on about the social gradient. So classify people by where they live, classify where they live by degree of deprivation. The greater the deprivation, the shorter the life expectancy. Now look at regions of the country. The Northeast in England's not like the Northeast in the US. This is not Boston. This is Appalachia. This is post-industrial decline. If you're rich, it doesn't much matter where you live. And the US figures are pretty similar to that. The greater the deprivation, the greater the disadvantage of living in the Northeast compared with living in London. Or putting it differently, for a given level of deprivation, your health is worse if you're in the Northeast. I've been asking myself the question, why is that the case? And I don't know, so I can now say anything. I suspect it's because the structure of advantage and disadvantage is different. If you're deprived in London, there's lots of employment and opportunities. If you're deprived in Newcastle, much less opportunity. Now, look at what happened over time. The dotted line, London, can't work the clicker, can't work the pointer, but everything else is working fine. The dotted line is 2011, the solid line's the later period. London, there wasn't much change over time. Look at the Northeast. Life expectancy declined between 2011 and 2021 in the most deprived decile. It declined in the next decile and the next and the next and the next and the next. In fact, life expectancy didn't improve for the bottom 70% of the population. And then you get maybe a small improvement. So the legacy pre-COVID of, we think, a decade of austerity, which is what I documented in my 2020 review, the legacy of that decade was slowdown in health improvement, increase in inequalities, and decline in life expectancy and health in the most deprived area. And similar picture for women. Proportionate universalism. What's this about? In my 2010 review, I tried to combine two ideas. The typical approach to social policy in, I'd say, English-speaking countries, in the US as well as the UK, is you focus on the most deprived, the poor. In the Nordic countries, in the Netherlands, they have universalist social policies. You have it for everybody. So I said, let's combine them. Let's have universalist policies with effort proportionate to need. So we could call that leveling up. If there's a social gradient, greater affluence, less deprivation, better health. If we focus only on the most deprived, we might improve their health. But what about the people who are above the threshold of intervention? So I said, universalist policies with effort proportionate to need. You can see why I'm not a politician. Could you imagine? Follow me to the barricades. What do we want? Proportionate universalism. When do we want it? In the fullness of time. What did we get post-2010? We plotted life expectancy for every local authority in England in 2010-12. And then the subsequent reduction in local government spending power up to 2020. Got that? So what you see is the shorter the life expectancy in 2010-12, the steeper the subsequent reduction in local government spending power. And I looked at this and thought, the kindest explanation I can give for this is absent-mindedness. They didn't know what they were doing. That's the kindest explanation, sheer incompetence. But it doesn't look like that, does it? It looks pretty systematic. In what moral universe can it be the right thing to do? The poorer the community, the more money you take away. And when people like me then point out that health inequalities are getting worse, that health for the poorest people is declining, they say it wasn't us. We didn't do it. What did you think would happen if you reduced the funding to local government by 59%? What did you think would happen? Nothing. Did you think local government was wasting all that money so you could cut it and nothing would happen? Predictable. For what it's worth, a former minister in the Conservative government invited me for coffee, and he said, you know, the present government doesn't like you. And I said, I kind of guessed that, but to hear it so bluntly. But the good news is here in the United States. Health expenditure, life expectancy. It's gargantuan, the gap in health expenditure between the US and other rich countries. And it's a bit troubling that you're not getting anything for it. So let me extend it to 2023. You'll notice that back in 1980, life expectancy in the US was rather similar to other rich countries, and the gap opened up and kept opening up. What happened in 1980? Some of you might speculate that it was the election of Ronald Reagan, the introduction of neoliberalism. I couldn't possibly comment. And if you look at inequalities, okay, let's look at white males in 2010, low education, middle education, high education, a social gradient. And it's true for every other group here, a social gradient. Now, look at what happened between 2010 and 2017 for white men and black men with low education. Life expectancy declined, got worse. Pretty dramatic black-white difference, didn't change that much. And for those with middle education, life expectancy declined between 2010 and 17. It improved for those with high education. The result, an increased social gradient. Inequalities got bigger. And this was pre-Trump. In a way, that caused Trump. Trump didn't cause this. It was these kinds of problems. And luckily, he's made them all better. And a similar picture for women. Of course, when you talk about health inequalities, or as you call them, health disparity. Oh, can't say disparity, can you? Systematic differences according to people's social and economic. No. The first thing people think of is access to health care. This recent paper looked by education, high education, medium, and low. That's adjusting for age, sex, and race, and then adjusting for health care, insurance, affordability, and availability. The authors of the paper said healthcare is clearly making a contribution to the social gradient in life expectancy. Yeah, a little bit. It's not nothing, not much. Good heavens, it's not much. So you've got this social gradient. You've got to look at the broader issues beyond healthcare. Oh, stop it, Michael. Keep carrying on. Look at this. Maternal mortality. What's the right rate of maternal mortality for a rich country? That's the right rate, 0. That's what it is in Norway, none. That's the right rate. All right, Switzerland, Sweden. The US, 22. Sweden, 2.6. 9 times. 9 times. What the hell is going on? No one's ever seen figures like this ever before. This is the people are saying this is amazing and wonderful. I'll give you. I'm not going to go through all my recommendations. I'll show them to you in a moment. But the first in all our reports is equity from the start. Give every child the best start in life. The Pew Research Center surveyed people in 36 countries, and they asked the question, will children be financially better off or worse off than their parents? In the UK, 19% of people think their children will be better off than their parents today. The US, a bit more optimistic, falsely so, I would say, but a bit more optimistic. 26% think children will be better off than their parents. We have failed a generation. Absolutely failed a generation. And you know what? I think these people are right that children will be worse off than their parents. And it doesn't have to be that way. And this is one of the reasons children in relative income poverty. Poverty is defined as living in a household at less than 60% median income. Among, this is from UNICEF, among 39 OECD countries, the Rich Country Club, the US ranks 35th, 1 being the least poverty, 39 being the most. So there's Colombia, but there's the US. I do like the US. You're the only country that makes my country look relatively okay. And, well, you don't hear. This is the rise in poverty. The US had the biggest rise in child poverty of 39 OECD countries over this period up to 2021. When in my 2020 report, the 10 years on report, the Prime Minister, the Conservative Prime Minister, he was asked, Professor Marmot reports that child poverty is going up. What do you plan to do? And he said, but absolute poverty is going down. I won't spoil your afternoon by telling you how they measure absolute poverty. But if we take a meaningful measure, the Joseph Rowntree Foundation measures destitution. Destitution is doing without 2 or more of housing, heat, light, clothing, food, and toiletries. In 2022, 1 million children were living in a state of destitution. A 2.5-fold increase in 5 years. Children being admitted to hospital with scurvy and rickets in the United Kingdom in 2022. And when I had politicians from the government say, we've reduced absolute poverty. Look at this, mate. This is what you've done. And people say our children will be less well off than we are. Yeah, they will be. This is why. And just to rub it home, in general, as gross national income increases, child poverty, of course, gets less. And there's the US, a complete outlier. Child poverty is a political choice. This is spending on children. In 2010, these orange ones, and 2019, the bars. I mean, the good news in the US is it didn't change. You were totally miserly when it comes to children in 2010, and you're still totally miserly. Still, you got up a bit compared to Mexico. It got a bit worse, but everybody else spends more on children than the United States does. I can hear you screaming, give us a break, you know. And child poverty is pretty important. Again, from UNICEF, if you look at the effect of poverty at measures of 14-year-olds, low word recognition, in other words, poor literacy, no poverty, one-off, intermittent, and persistent. Huge effects of poverty on low word recognition at 14, poor or fair health, emotional and behavioral difficulties, depression, low subjective well-being. So childhood poverty, and the more persistent it is, the bigger the effect, has a big effect. The third most common question I get asked is anyone listening to you? And the answer is, the evidence-based answer is yes. One example, Winnie Byanyima, the head of UNAIDS, invited me to co-chair a high-level council on inequality, AIDS, and pandemics. The co-chairs were Joe Stiglitz, Nobel Prize-winning economist, and Monica Gangos, former First Lady of Namibia. We launched it in Brasilia, and we reported during the G20 meeting in South Africa in November last year. And we had 4 domains of recommendations. The financial barriers, we were thinking about AIDS and pandemics, but I would argue that these apply to health more generally. The global financial architecture is not conducive to health. Social determinants, of course, not just pandemics, but in non-pandemic times. Local and regional production, vaccines. There was huge vaccine inequity during COVID. And build greater trust, equality, and efficiency, which is related to what we've been hearing in these case studies. So debt, economic resilience, etc. This is what's happened to private wealth globally and public wealth. The private sector is doing okay. The public sector is doing very badly. Look at this figure. This is the wealth of billionaires. In the first year of the pandemic, the wealth of billionaires went from around $9 trillion to around $14 trillion. Billionaires increased their wealth by $5 trillion in the first year of the pandemic. They had a very good pandemic. Now look at people in food insecurity globally. We've got 2.2 billion. Now, I'm not very good at sums, but I think a trillion is 1,000 times a billion. So if that increase in wealth in the first year of the pandemic, notionally, had been applied to doing something about food insecurity, that would be $2,000 per person globally for the whole world. And the poor old billionaires, they'd have to make do with $9 trillion. They'd get by. If we look at income inequality and the impact on COVID-19 mortality, this is US states, but it was true for countries as well. The greater the Gini coefficient of income inequality, the higher the COVID-19 mortality. And we see it globally. Invest in the social determinants of health. You'll never guess which member of the council that came from. These were the 8 Marmot principles that we adapted for the Global Council. We developed them for our reviews in England. Give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, having enough money, having the basic income for a healthy life. Number 5, healthy and sustainable communities in which to live and work, including housing. Number 6, taking a social determinants approach to prevention. Number 7, tackle racism, discrimination, and their outcomes. And number 8, pursue environmental sustainability and health equity together. Global access to vaccines and medicines. You'll be pleased to know, well, you won't actually, but there's good data. When USAID was fed into the wood chipper, the estimate was that there would be 5 million extra AIDS deaths in the next 5 years. You depressed? The second most common question I get asked is, why aren't you depressed? It's all going to hell. How can you keep doing what you're doing? When the government changed in Britain and the Conservative government was more interested in austerity and didn't like me very much than in implementing my recommendations, the English city of Coventry said, we'll be a Marmot city. They took what was then my 6 recommendations, the first 6, and said, we'll implement this in Coventry. So then I went to the mayor of Greater Manchester. You've heard of these places because you watch the Premier League on television, so you know about Manchester. I went to the mayor of Greater Manchester and said, they're doing this in Coventry, but who's ever heard of Coventry? If Manchester did it, he said, we'll do it. Then I went to Liverpool and said, do you know what they're doing in Manchester? And I went to Newcastle and said, you know what they're doing in Liverpool and Manchester and Birmingham? And it's epidemic. We now have 60 Marmot places in England, Wales and Scotland. Scotland asked us to help with a national strategy. Wales, not to be outdone, said, we will be the first Marmot nation. And we launched in Cardiff a few weeks ago. So it's really exciting. Spain has asked us to do a national strategy for them. We're talking to other places. It really is exciting. And these are our 8 recommendations. And what does it mean to be a Marmot place? Well, take action on the 8 Marmot principles. Second, strengthen cultures and systems for health equity. I've got Medway here because we did a launch in one of our areas last week in Medway. Strengthen partnerships, engage with anchor organization, and then transformational processes, accountability, monitoring, and the like. And we work in partnership. The community and voluntary sector, Bernardo's, which is a children's charity, with the business of health equity, the Marmot Review for Industry, of course, with healthcare and other public services, and with local government. For business, we in public health have always seen industry as the enemy, for good reason. All the, commercial determinants of health and so on. Legal in general are not small financial services company. They have under investment 1.3 trillion pounds. I know a pound's not what it used to be, but it's not trivial. They have 1.3, so they're not tiny. And we said 3 areas of recommendations. Your employees, pay everybody a real living wage, good conditions of employment. Goods and services, if you're the tobacco industry, we can't work with you, finish, end of story. If you're the food industry, which side are you on? Are you making everybody unhealthy or providing nutritious food at reasonable cost? And thirdly, the wider impact on the community, the environment, and the like. And I began by saying that health is a measure of the nature of society. If health's not improving, it means society's not improving. What kind of society do we want? Freedom has been captured by the political right. Isaiah Berlin said, freedom for the wolves has often meant death to the sheep. So one kind of freedom isn't going to help us very much. I'd rather Amartya Sen. We're trying to create the freedom to lead a life you have reason to value. I can't tell you what a valuable life is. What I can do is say, what are the conditions that enable you to lead a life that you have reason to value? I said Joe Stiglitz was the co-chair of this commission. He gave me a copy of his latest book. The challenge was for me to read it before he published the next one. And he called it The Road to Freedom because in a way he was saying this is the end of neoliberalism. Friedrich Hayek published The Road to Serfdom, which ushered in neoliberalism. And Joe is saying this is the end of it. And he's got a whole series of evidence-based recommendations. Based on the kind of things I've been showing you, the Marmot communities and the like, I used to go around the world saying I was an evidence-based optimist. And a Portuguese colleague, a Brazilian colleague, speaking Portuguese, said, Michael, you're using the English language incorrectly. Go on. He said, you're not optimistic, you're hopeful. What's the difference? Well, an optimist knows things are going to get better. It's the opposite of a pessimist who knows things are going to get worse. And if you know things are going to get better or worse, why do anything? Just sit back and watch it all play out. But hope is the opposite of fear. If you're hopeful, then there's something we can do together to try to make a difference. I think I've got evidence-based hope, not evidence-based optimism. Václav Havel, who was a Czech dissident, playwright who became the first leader of post-communist Czechoslovakia, said, hope is not prognostication. It's not a prediction. So it's exactly this. It's not the same as optimism. It's an orientation of the spirit. an ability to work for something because it's good, not just because it stands a chance to succeed. Colleagues, join my social movement of evidence-based hope. Thank you.
Thank you so much, Sir Michael Marmot. I think just being able to say what you said out loud in the United States right now is music to our ears.
They may not let us back.
They may not let you back another time. Okay, that was a wonderful talk. We're going to alter our program a little bit so that we can get out to the reception and continue the conversations. We've got time for just 2 questions if anybody wants to raise a question.
Thank you, Sir Michael. It's a real privilege and pleasure to hear you again. The 8 Marmot principles, do you think that any jurisdiction can implement those from the top down, or do you have a recipe for bolstering the local democracy so that communities can organize to hold leaders accountable for implementing those principles and shifting these institutions towards equity?
It's a brilliant question. The first thing is I don't have a recipe. I have a set of principles, and we work with local government. And I mentioned, just because it's on my mind, that we launched a report in Medway. What they did in a very systematic way is go out to the community and more or less say, what is it you want? What do you, and they really did it. And I said it was a model for other Marmot places, what they were doing. And all of our places, one way or another, but Medway did it the best. Go out into the community to say, what is it you want? What are your demands, desires, needs, and the like? And not surprisingly, if you ask people about health, it would be the same in the US. They'd say difficulty getting to see the doctor. When my grandma was in hospital, the nurses were terrific. You know, the nurses are always terrific. And that's what they think about health. But when they talk to them about what's going on in your life, then they talk about housing, and they talk about children, and they talk about education and neighborhoods and crime, and they talk about all those things, which of course are relevant to their health. So we haven't got a recipe, but we try to get our local partners as their first step to engage with the community. The other part is charismatic leadership. So you need both what's happening in the community. When we started working in Scotland, and I said charismatic leadership, and they said, this is Scotland. We don't do charisma in Scotland. Well, all right, the best you can do for, but you need the commitment from, and it's not just the health and care sector. You need the political leaders and you need the chief executives of local government, but it starts with the people.
Thanks for that wonderful answer. Is there one other question?
Thank you, Sir Michael. My name is Isha Ray. I'm a professor in the Energy and Resources group here, and most of my work is on water and sanitation. So there's a very common phrase in the US, and it's slightly pernicious. It's called private-public partnerships. You never really know on whose terrain who is partnering whom. And what I wanted to ask you, especially because of your last slide, is on a very practical level, for reducing health disparities, we'll say the D word here, what is the role of the private sector?
Well, I've been worrying about this for a long time. And when I led the WHO Commission on Social Determinants of Health, I went over to the ILO, the International Labour Organization, and talked to the Secretary General and said, we want to get business involved. And nothing really happened. And I tried a couple of times in the UK and nothing happened. I was then approached by Legal and General, and the chief executive grew up in Newcastle in the Northeast. And yeah, remarkable man. When I told him that I was co-chairing a commission with Joe Stiglitz, he said, he taught me at MIT. So this man who grew up in the slums of Newcastle, went to MIT and got a PhD and then became chief executive of this huge corporation. So this is a man that's extraordinary. I mean, we were coming back on a train together once and I said, is Legal and General the kind of organization it is because you're the chief executive? Or are you the chief executive because of the kind of organization? He was too modest to answer directly, but it was clearly he had driven that organization. So you get a remarkable person like this, and corporate social responsibility starts to mean something. It's not just, what you've got to tell your shareholders, CSRs, what we do. They supported that report we did. They support a health equity network that we established, and they put £3 million into a health equity fund, £1 million for the Northeast, because that's where Sir Nigel came from, but £2 million around the country, 42 projects, people, helping kids and doing things with single mums and food banks and, small scale, but it comes back to your question about the community, doing things at a community level. But that's extraordinary. I can't give you all the other businesses we're working with. We'd like to work with more. Sup with the devil, use a long spoon. You've got to be a bit careful. We'd like to work with more, but we've at least we can tell others, look at the Legal and General example.
Thank you so much. I want to thank Sir Michael Marmot, of course, that was amazing, and the wonderful panelists and the cases they presented. It's been an extraordinary experience for all of us to learn so much that you've brought to us today. So now we get a chance to go out, and I hope everyone will continue this conversation out in the reception that's planned for us. So thank you, audience, and thanks panelists, and of course, our keynote speaker, Sir Michael Marmot.